All right, let's go ahead and get started here. So admittedly, I haven't graded any of your homeworks yet. I had every intention to do that yesterday, but the last 2 days I've kind of stumbled into a class that I'm teaching where about a third of the students have been cheating the entire time. So needless to say, that's kind of taken up a lot of my time these last couple days here. I will say that, granted, as a professor, I'm staunchly against cheating and academic dishonesty. It's kind of one of the things that grinds my gears the most. But if you're going to cheat, it's probably in your best interest to not say, like, leave the original author's names on the paper, or, you know, maybe the school they went to when it's not yours, that kind of thing. You definitely don't want to be using anybody's papers or assignments that I have taught before. Um, yeah, that's probably not the smartest of things there. But yeah, just wanted to share that real quick. I mean, seriously, I guess I'm going to answer my own question, but how dumb do you have to be to turn in someone else's work and not at least put your own name on there instead of their name? But whatever. All right, so we got our first exam this week. It's going to be on test moz, and I will open that up after class on Friday. And I'm going to give you, since we're going to finish Friday at like 6:20, 30, whatever, I'm going to give you until Monday night to finish it. So, well, actually, I don't even have to change this, but you'll have until Monday night to do it. You'll get, all right, so this class would normally be an hour and 45 minutes. So you're going to get that full hour and 45 minutes to do the exam. The other section that just took theirs, it took them on average like an hour to do, and average grade was around an 80%, so pretty decent there. I'll make sure to actually review with you on Friday, but you're going to have 44 multiple choice questions, and then you're going to have 4 math questions. And I'll just tell you straight away that the system, like the computer system, doesn't do well with recognizing like different words that aren't different. So for example, if your answer was 100 joules and you wrote it as 100 space joules, these aren't the same thing according to the computer. So keep that in mind with the math stuff. If the math problems are marked incorrect and you know you have the correct answer, I'm going to go back and change it. So don't freak out. I've put a few notes in there to remind you, like, hey, if you missed this, or if it says you missed it, but really you got it right, don't worry. I'm going to fix it for you. I don't want to, definitely don't want to cheat you out of any points or anything like that. But yeah, and it's 150 total points. So each multiple choice question is 3 points, and each math question is 4.5. Any questions on that so far? Oh, and it's just topics 1 through 4. So today we are getting into topic 5, which is the shoulder. So this is one of my more fun ones. And it's also nice we finally get to start, talking about the body itself. All right, so with the shoulder, there's a few important things. There's several kind of unimportant things. I'll make sure to point everything out for you, what you need, what you don't need, all that good stuff. So first off, with the shoulder, you have 4 joints. You've got really 3 bones. And then you have a whole lot of soft tissue. So if you look at our continuum here with stability versus mobility, where do you think the shoulder fits on this continuum?
It's extremely mobile.
Yes, and it's our most mobile joint that we have. So shoulder, probably way over there. What's our most stable joint?
Would it be your hip?
No.
Skull sutures.
Yep. How much do those move?
Not at all.
Hope not. I don't know if that'd be a really impressive party trick or something to be terrifying. But yeah, you don't really want your skull to be moving around. So anything that's a synovial joint. A synovial joint is anything that has a joint capsule and allows movement. If it's a synovial joint, automatically it's somewhat mobile. If you're not a synovial joint, which like the sutures in your skull are not, that automatically is going to put them on the much more stable side of things because there is no movement for them. If you have no movement, you are automatically more stable. With our shoulder, now, when I refer to the shoulder, I'm referring to the glenohumeral joint, which is this one right here. So that's really the shoulder proper there. And when you refer to, say, the arm, we're talking about the shoulder as well. So if you move your arm, you're talking about moving your shoulder. Now, the bones we have. So these 4, your scapula, your sternum, your clavicle, and your humerus. I'm calling the manubrium part of the sternum, but either way, this isn't really important at all to us. Your sternoclavicular joint, which is right here, this is considered part of the shoulder complex, but it really doesn't do anything. I mean, it has a tiny bit of movement, but for the most part, it doesn't do anything. I mean, so that's the one really don't worry about. The other joints we have are going to be right here, all this here, and then this guy here. All your joints are just named after the 2 bones that are attaching to it or that come together there. So this one here, you have your acromion and your clavicle, making this your acromioclavicular joint or your AC joint. We're missing our ribs, so the ribs would be here. But this is your scapulothoracic joint, and it's really more of just a kind of, this is the pseudo joint they're talking about, but it's just where the scapula sits on top of your ribs. There's no real joint there, but it just kind of stays in place. And this one here, the big one, that's your glenohumeral joint. So humeral for the humerus, and then your glenoid fossa for the gleno portion of it. Now, I'm not so concerned that you know every single bony landmark. There's a few I do want you to know, and we'll go over those as we come around. So don't get too caught up in knowing every single piece of the anatomy, because this isn't an anatomy class. You need to know some of the prominent things, but at the same time, don't worry about knowing every single piece of anatomy, since you already took that class. Which, I mean, technically, I guess you should already know it then, so you should be expected to know it. I had a training I had to take yesterday that one of the points they discussed was talking about how you can have strengths that are actually weaknesses. And I was really trying to think about, like, what does that even mean? And I spent, like, because granted, this was really, really boring, and this is like one of the first things they talked about. But can you think of something that's a strength for you that would be considered a weakness? Because I really can't think of something like that. I go from the perspective that if it's a strength, well, it's a strength. I guess I wouldn't want to be, like, say, I don't know, good at robbing banks or something. Anyway, one of the, well, I say a couple of the major landmarks you should remember is our spine and the scapula. Then you want to know your superior and inferior angle, and then you want to know your supraspinous fossa. Any fossa you have is just like a bowl or a cavity. So you do want to know the glenoid fossa, but that's going to be pretty, much straight away for you. All right, sternoclavicular joint, like I said, doesn't really do a whole lot. So don't worry about this. Now, our AC joint or acromioclavicular joint. This primarily is used to add additional kind of bony stability to the entire shoulder complex. So when we look at the shoulder itself, and again, when I talk about the shoulder, I'm referring to the glenohumeral joint. There's absolutely no bony support to this. It's essentially a golf ball sitting on a tee. So all you have is soft tissue to support it. The AC joint is here to essentially stabilize the acromion to the clavicle, making it so that the scapula is a lot easier to maneuver. Now, if you were to, say, injure this, and actually it's on the next one here. Here we go. Anyone know who this is? It's probably a little bit before your time. And actually, I'm not even sure if he's still even playing football or not. Nope, he is not. Oh, damn. He's only 33? Anyways, this is Sam Bradford. Wow. Anyway, so Sam Bradford was the first quarterback to, or the first player to win the Heisman Trophy as a sophomore, but he had lots of problems with his AC joint. So whenever you hear the term of having a separated shoulder, you're referring to an injury to the AC joint. So a shoulder separation and a shoulder sublux or dislocation are not the same things. So a shoulder separation means that you have a tear in the AC joint. If you have a sublux or a dislocation, you're referring to the glenohumeral joint. And if you had a complete tear of this, so if you had grade 3, and the way that tears are measured in the body is on a 1 to 3 scale. 1's your best, like the least injured thing. 3 is like a complete tear of everything, like destroyed the whole thing kind of thing. And a sprain refers to any tear in a tendon or a ligament. A strain is a tear in a muscle. But if you completely tore this, the procedure to put it back together is to keep it separated. You actually reroute one of your main ligaments here, taking it off the acromion and putting it straight on the clavicle. This serves two purposes. It helps stabilize the clavicle in the same way that the acromion would have, but it leaves more space available for you so you can actually do stuff in there. This space you have right here is called your subacromion space. And how big do you think that is?
One centimeter.
Actually, roundabout there, yeah. This all is everything you have to fit all this extra stuff that goes below the acromion, but essentially above the humerus. So depending on the position and forming of your acromion, yeah, you're talking like at most a centimeter. So around about like 4 to 10 millimeters is usually about all you have. So roughly it would be about the width of your pinky nail is about all you have. So very, very tight space. This is why, like, say, anytime you have something going wrong in your shoulder, it can be catastrophic because you just have no space at all there. Now I'm going to jump back to the scapulothoracic joint here real quick. I wanted to I don't have it in here. Anyways, we're talking about the acromion. There's 3 basic, essentially, styles of how this is made. And it all just has to do with how much of essentially a hook there is on there. So if you have this type 1, you pretty much have a flat acromion, which is good. Type 2 and type 3, you see how these are much more hooked. And what you see here is just how much available space you have. The more of a hook you have on that acromion, the less space you have for it overall. Sometimes when you get, like, say, a rotator cuff tear or like even a labrum tear, you need to go have surgery, you'll get a procedure done known as a subacromial decompression, which essentially just means that part of this bone gets shaved off. So it creates more space in your this overall subacromial space. People who have type 2 or type 3 acromions and are overhead throwing athletes, so people that throw like a ball, much more likely to injure their shoulder than someone who has a type 1 shoulder. Part of that whole, genetics thing. Now, for the scapulothoracic joint, the main thing with this is how it interacts with the glenohumeral joint. We'll talk on probably Friday about it, about the concept of scapulohumeral rhythm, which I'm sure you've all had in lab already. But you need the scapula to be able to upwardly rotate to clear space for the humerus to abduct. Otherwise, it would run right into the acromion and lock in place. Now, even though this isn't a synovial joint, it still has quite a bit of movement because there's no real restrictions on it. You don't have anything like any bony prominences locking this in place or anything like that. It's only soft tissue that really holds the entire shoulder complex together. And I'll talk about the movements here a little bit later. Okay, as far as muscles go for the scapulothoracic joint, if you don't remember any other muscles, remember the traps. Trapezius is the kind of granddaddy of the scapula. Anytime the scapula moves, trapezius has to move. If trapezius doesn't move, the scapula doesn't move. Your traps, while kind of technically one big muscle, is actually split up into really 3 functional groups. So your origin points for this are really at the base of your occipital bone and then all the way down your entire cervical and thoracic spine. So if there's ribs, there is trapezius. Now, your upper fibers are the ones that are your shoulder shrugs. So these here, those are your upper fibers. This guy right here, that's your middle fibers. And then kind of in here, that's your lower fibers. The lower fibers aren't anything special. Your middle and your upper fibers are the ones that really do the bulk of your work. So the shoulder shrug or upward elevation of the scapula, your upper fibers, and then your middle fibers are going to help to squeeze your shoulder blades together. They're going to help with upwardly rotating your scapula. So they do quite a bit with there. Your lower fibers kind of just depress the scapula. So they don't really do a whole lot of action on their own. It's kind of just returning you to where your regular position is. The movements we have with the scapula are up, down, left, right, ABC pause. So your scapula is able to move straight up, straight down. It can move inward, it can move outward, and it can rotate up and down. So this movement upward is scapular elevation. That is your shoulder shrug. Adduction, or you may also hear the term retraction, that is where you squeeze your shoulder blades together. Depression isn't really a movement you can do on its own. So you can't lower your scapula any lower than where it's at rest. you can only depress the scapula after it's been elevated. So that's why I say like the lower fibers of the traps aren't really all that impressive, just because they only return you to your original point. They don't make any actual major movements on its own. All right, it's not showing me a good word to use, but this bit here going away is your protraction or your abduction. So if you were to say reach out in front of you, that is going to help to protract the scapula. And then this upward and downward rotation is used in concert with your humerus. So when you abduct your humerus, you are going to upwardly rotate the scapula. When you adduct the humerus, you are going to downward rotate the scapula. Pretty simple. Hopefully this is kind of a review for you from your lab. Where are you all at in lab anyway? What body part?
Hip and pelvis.
Okay, so you're way out there. Have you already done your first exam or your first practical, whatever?
Yeah.
Okay. Very good. Gosh, what, like, seriously, what were you guys doing for the first 5 weeks? I mean, you're like 3 weeks behind on all this stuff. All right. The muscles you're going to need to know for the scapula are your levator scapula, traps, rhomboids, and I believe that's it. Oh no, serratus anterior. I think that's about it. Anyways, levator, this is going to elevate your scapula, so it helps you just with that shoulder shrug. Your rhomboids are your major scapular retractors or adductors, so squeezing your shoulder blades together. Serratus anterior, this one is a little bit tricky. So if you look at where it actually originates, it's really technically your first 9 ribs. But the way that it works is that it inserts all along the lateral border. So it helps to kind of pull your shoulder blades out when they're protracted. It does a little bit with upward rotation. So like when you abduct your humerus, it'll help to upwardly rotate the scapula. What's a little bit like weird about it is how you actually say train it, because you don't train it in the same way that it kind of technically should move. Primarily, the only exercise you do for your serratus anterior is a serratus press, where you have essentially a supinated grip on a bar or dumbbells, and you just lift straight above you. That's really the only way that works. Pec minor, I'm not too worried about, because it's anything it does is synergistic, so it doesn't do any real agonistic movements on its own. Now, here is where this all kind of comes into play, because this is our force coupling. Do y'all remember force coupling? Perfect. The way I like to explain it is if I'm driving a car, or driving a top hat, and I'm going forward, what direction are my tires going? Well, at least I can see now why there's no parking issues this year, because apparently none of you drive. Yes, you are rotating them clockwise. Now, that is the entire movement, is that these rotate clockwise. However, if you take each segment of the tire goes in a different direction. The top of your tires go forward. The anterior portion of your tires go down. The bottom portion of the tires go backwards. And the rear posterior parts of the tire go upward. Those are 4 basic movements for, well, I guess any wheel. But they all combine together to give you a forward directional movement. That's the same thing that's happening here with the force coupling we see in the scapula. You have your serratus anterior, deltoids, your traps, and this would better be said as your rhomboids here. But they all move in different directions. But in the aggregate, they give you that same upward rotational movement. It's kind of like if we're trying to, say, move one of the desks in any of the classrooms. If I get on one end and push it, and you are on the opposite end pulling it, we are moving in different directions. I'm moving forward, you're moving backward. But in the aggregate, we are moving or operating on the same directional component. Kind of make sense? All right, this bit here, this is what is known as your upper cross. You also have one at the hip and pelvis called your lower cross. But while this person's like over exaggerating this, what she's demonstrating here is how our body tends to have opposite sides that are weak and tight. So for the most part, even if you're sitting with relatively good posture, you're going to be sitting with your neck slightly forward. I mean, how many of you are sitting here with your neck like an extension kind of thing? I mean, really can't. I guess if you were, you know, like in some sort of like gaming chair and you had your monitors up here, I guess, okay, which would actually be quite a bit better for you now that I think about it. But for the most part, everyone is going to have some degree of neck flexion going on. And what happens is that your neck flexors end up becoming weak because they aren't being used. That's the position that you are essentially stuck in. What happens behind them is your upper traps and your levator scapula become very tight. I mean, how many of you ever, you know, get a massage and say that, no, my neck feels perfectly loose and great? It's actually the front of my neck that's giving me the problems here. So your upper back and neck tend to be tight. The front of your neck or your neck flexors tend to be weak. That's because of the position you sit yourself in. Conversely, pecs tend to be tight. And then your rhomboid, serratus anterior tends to be weak. Now, she's actually showing the perfect position. You can't quite tell here, but of what someone would experience with tight pecs. How do you tell if somebody has tight pecs?
Their shoulders are rounded.
Kind of. If you mean by rounded, they are internally rotated. So when pecs are tight, you internally rotate the shoulders. Easiest way to tell, you watch somebody walking. Oh, geez. Gotta watch out for sitting. It's gonna do my knees in even when they are. Oh, sorry, hold on a second. gotta let the hound out. But anyways, if I'm walking and you see the back of my palms, this is your signal that you have tight pecs. So next time you're walking around somewhere, look and see whomever you can see walking with the back of their palm showing, or the back of their hand showing. Who calls it the back of their palms? Jeez. If you see the back of someone's hand while they're walking, that means they have tight pecs. And while you should be walking, functional position there, you turn over to get into internal rotation. Internal rotation means that you have that tight chest muscle there. So how you fix something like this? Well, you don't really need to say strengthen the neck flexors. What you primarily need to do is strengthen these and stretch these. Now, these two, pretty easy. The best way to kind of stretch this stuff is to do what's called neck retractions. So you kind of give yourself a double chin and pull your neck back. And you'll feel a stretch really at the back of your neck if you do that. So that's something that is really helpful to be doing just throughout the day. All right, and this bit here, real quick, this is what's known as your arc of pain. This is kind of an incomplete picture because you would get actually additional pain at roughly 170 plus degrees. However, it's different because that's for your AC joint. We're going to cover the glenohumeral joint next, but this arc of pain is what you would experience if you have typically some sort of injury to the glenohumeral joint itself. And that's just because once you start abducting your arm, you start impinging that subacromial space. Anytime you impinge something, you pinch it. If there's any pathology in there, then you are going to essentially aggravate it. So kind of think of have you ever had, I don't know, let's say an infected fingernail, you bit your nails and it got infected or something like that? I'm going to wager my life that at least one of you have had that happen to you. But if you've ever had any infection at all and you touch it, what does that feel like? Did I just make a terrible bet? All right, so I had a splinter in my hand right there that you can see. I'm sure somebody's had a splinter before. All right, Hector, thank you for nodding, even if you're lying. If you let that splinter in and you were playing around with this, how's that going to feel?
Feels like it's pinching or stabbing something.
There we go. Geez, taking you to the dentist. So whenever I impinge or cut off that subacromial space, that's where I'm going to get this arc of pain here. Once you get past 120 degrees, that's where you have kind of more relief from it because you have additional upward rotation of the scapula to give you more clearance. At 170 plus, if you have an AC joint pathology, that's where you're going to feel it. So if you want to test your AC joint, hand over your shoulder, and you would push down on the elbow and try to resist it. If you had an AC joint tear, you would fall straight down. And then doing essentially a serratus press, but without anything. And then if I can pull down your arm, that would say that you have an AC joint, some sort of AC joint pathology. Have to be in supination though. So your hands need to be, or palms need to be facing you when you do that. If I wanted to test your rotator cuff, I'm going to do primarily scaption. So scaption, I have 90 degrees of flexion, 90 degrees of abduction. Scaption is right in the middle. If you had a rotator cuff tear, roughly 90+% of the time, it's going to be your supraspinatus that's going to be the problem. And as you remember from lab, when you do a manual muscle test on the supraspinatus, you do that in scaption. Now, the other thing too that I wanted to point out is, and we'll see this again when we do, I think, the wrist and hand, is that the normal ranges of motion you'll see are sometimes grossly different based on the source you use. So for example, the lab and the lecture don't usually have the same normal ranges of motion, which you would think, we'd all be on the same page with that, but whatever, we're not. So your lab tells you that shoulder flexion and shoulder abduction have a normal range of motion up to 180 degrees. Abduction does. So you should be able to abduct your shoulder to about 180 degrees. Flexion, you actually only get roughly 160 to 170. But I will make sure to honor any norm you have, as long as it's in either lab or lecture. Have any of you taken any athletic training classes, like specifically like the athletic injury class? Oh no, because those are completely different as well. So, sorry, Liv. I actually got a complaint about that before, that the information being presented in the lab portion of the class was not the same as what the athletic training program was saying. So therefore, I was wrong. All right, now getting into the kind of most important of our joints here is our glenohumeral joint. So when you talk about the shoulder, this is what you're talking about. Like I said before, the glenohumeral joint is kind of like a golf ball on a tee. There's really no bony support that goes into this. The only thing that's supporting this joint is soft tissue. That's good because it gives you a lot of mobility. It's bad because it gives you virtually no stability. I mean, you sneeze and you can dislocate your shoulder, kind of thing. If you're Dwayne Wade, you also lose the ability to walk every time you dislocate a shoulder. Now, this bit here, you can tell how old this is here too, just by the wording it uses here. This bit here is your labrum. Your labrum is a really donut-shaped piece of cartilage that lines that glenoid fossa. Its whole role is to give you additional support between the head of the humerus and the glenoid fossa, and it also helps to deepen the cavity a little bit. So you get a little bit more of a suction into there. Your labrum's cartilage, and it's largely avascular, meaning it has very little blood supply to it. If you tear cartilage, it really doesn't heal on its own. The other important thing about the labrum is this here. because the long head of your biceps is going to insert onto the superior labrum. This is why something like, say, having biceps tendonitis can be actually pretty serious, because if you have it, and assuming it's at the shoulder area, you can very easily see how that can cause problems with the actual shoulder joint itself. When and or if this tears, you typically have what's known as a slap tear. SLAP stands for superior labrum anterior to posterior. So you're typically tearing this like that. Virtually all labral tears require surgery, again, because it doesn't have a vascular supply, so it really can't heal itself. So glenohumeral joint made up of the scapula and specifically the glenoid fossa attached to the head of the humerus. And there's your labrum there. I want to get to my, well, let me start here real quick. Bursa sacs. These are located all around really any synovial joint you have. What a bursa sac is it's really just a cushion that is also going to provide a kind of lubrication for the joint itself. If you were to actually look at and handle a bursa sac, it would have the consistency of like snot. And if you ever have bursitis, this essentially hardens up and it gets a little bit bigger. Remember, anything with the suffix itis refers to inflammation. Your bursa sacs, especially in the shoulder, are going to be superficial to virtually everything else. So if you get, like, say, any kind of tendonitis in your shoulder, I mean, yeah, that sucks. It's going to hurt, but it's not going to really debilitate you. I mean, if you're like, say, a baseball pitcher and you had, say, like biceps tendonitis, supraspinatus tendonitis, something like that, you probably won't be throwing much until that calms itself down, but it's not as though you really lose any major function with the shoulder. You get bursitis, on the other hand, and essentially this is going to squeeze up and take up your entire subacromial space. Whenever granted, I've never had bursitis myself, but whenever I've spoken to anyone who has had it, the description of it is always the exact same. And that is, I can't lift my arm past here. Essentially, once you hit that 60 degrees of abduction, you start impinging on the subacromial space. If it's already inflamed in there, you just can't move it. So you're talking about people that, like, you know, that's about it, what I can do for movement. You're not lifting anything above. I mean, you just can't, because your shoulder is essentially kind of, I don't want to say frozen because it's a completely different issue, but it gets stuck in this adduction type area where you really can't move it. Now, the shoulder, being your most mobile joint, has all the freedom to move that you can imagine. So you have 3 degrees of freedom with the shoulder. The movements you have here are your flexion extension, internal external rotation, but you also have these horizontal movements. So you actually have two sets of transverse plane movements that you would have with the shoulder itself. So flexion extension, pretty easy there. What plane is that?
Sag-
Yep, sagittal plane, and what's my axis of rotation?
Medial to lateral.
Medial lateral, yeah. Frontal plane movement, I have my ab adduction, which goes through what plane, or what plane, what axis?
Anterior, superior.
Anterior, posterior. And then when I do any of my rotational movements, internal, external rotation, transverse plane, longitudinal or vertical axis. Now, horizontal ab adduction is the one kind of glaring exception to where you would see the terms ab or adduction or even flexion and extension, and it refers to the transverse plane. Horizontal adduction is the same thing as horizontal flexion. If you have horizontal abduction, that's the same thing as horizontal extension. So if I start out with 90 degrees of shoulder flexion, let's do one arm to make it easier, and I come across my body, that is my horizontal flexion or horizontal adduction. If I take that and go behind my body, horizontal extension or horizontal abduction. These are both transverse plane movements, even though they're titled with a sagittal and or frontal plane movement. It's that horizontal component that makes them essentially a rotational movement. You can do this with the hip, but it's a lot more limited. Now, some of your other joints have, quite a bit of movement, but unless you have the ability to rotate the joint, you can't have true circumduction. So circumduction, or making a circle, that is primarily only achievable by, like, say, the hip and the shoulder. And it's because you have true rotation in these joints. If you can't rotate the joint, you can't have true circumduction. You look at something like, say, your thumb. Thumb's a saddle joint. I can rotate or circle my thumb about, but this really isn't true circumduction because I can't rotate my thumb. How many of you can, like, twist your thumb? I mean, I guess if I pulled it, kind of, but no, you can't do it. All it is a joystick. So your saddle joint is just a joystick. I can't rotate or twist these knobs, but I can move them in a circular fashion. So they can go up, down, left, right, and kind of in a circle, but I don't get that full 360-degree circular motion because I can't rotate them. With a shoulder, I can. All right, so any questions on the shoulder movement? Great. Okay, muscles for the shoulder itself. Pec major, your rotator cuff muscles. Whoops, not teres major. Deltoid, lats. Don't worry about this. Don't worry about this. So just like with the scapula, the shoulder itself has a, one kind of central muscle group, that's your deltoid. So Your deltoid will be involved in all glenohumeral joint movements. Anything moving the scapula has to involve traps. Anything moving the shoulder has to move has to use the deltoid. To a lesser extent, you should remember biceps and triceps. We'll cover those in a minute here. All right, so just like with the traps, you have three sections here. Or kind of three functional groups of your deltoid. So you got your anterior fibers, your middle or medial fibers, your posterior fibers. Any movement in the direction of the fibers is going to use those fibers, meaning that if I move forward or away from my body, I'm going to be using my anterior fibers. If I move in the frontal plane, I'm going to be using my medial or middle fibers. If I go posteriorly or I go behind me into extension, I'm going to use my posterior fibers. So it all comes back to this whole form follows function. Wherever your muscle fibers are facing, that's the direction they move the body. There's only really one exercise that's going to trigger all three heads or all three groups of the deltoid to work together all at the same time. And that's a behind the back or behind the head lat pull down. So if you do that whole behind the head lat pull down, that's the only exercise you can do to get all three heads of the deltoid firing together. However, not really a good idea to do that. And why do you think that is? So even just try to hold your arms in this 90-90 position, so goalpost, but make sure that you are slightly extended here. And how good does this feel when you're in this position? So again, make sure you're 90 degrees of abduction, 90 degrees of elbow flexion, and then go into slight extension so that your arm is behind your head, or the humerus is behind your head. And how does that feel? Well, I'm going to answer for you because I can't do this anymore. Does not feel that great. And it's all because you're impinging the area. Abduction impinges. Extension is going to impinge. External rotation is going to impinge. It's like the trifecta of how do I want to screw my shoulder up today? So if you want to effectively train all three areas of the deltoid and you don't have the time to sit and do multiple exercises, probably your best bet would be doing something like, say, a military press. Because even if you're doing a military press, you're at worst going parallel to your shoulder. It's when you go behind the head, you have major problems. It's kind of like if any of you have ever done the snatch before or have seen someone do that. Yeah, that's not the most comfortable thing to do. And, whole issue with, like, say, dislocating your elbows and all that good stuff also doesn't really fare so well. So keep your arms in front of your head. kind of thing. Now, pec major. This has two functional fiber groups. You got your clavicular fibers, and then you got your sternal fibers. Just like I was saying with the deltoid, the muscle is going to move the body in the direction that it's located, or the position it's located. Meaning that your clavicular fibers are going to move you upward. Your sternal fibers are going to move you inward. So if you put your hand over your heart kind of thing, so fingertips touch your clavicle and palm of your hand try to touch close to your scapula, close to your sternum. There you go. If you could do that, fingertips touching your clavicle and your palm of your hand touching your scapula, I would be truly impressed. You also must have an extremely large hand then too. If you take that arm and you lift it up, so you're going to reach for something off the top shelf, what do you feel contracting? Yeah, you're going to feel your clavicular fibers contracting. This is kind of like if you were doing, like, say, an incline bench press, you're getting primarily those clavicular fibers to work. Now, if you go straight forward or you do any kind of horizontal adduction, I mean, that is going to just absolutely hammer those sternal fibers. I mean, there's absolutely no question when you stay at 90 degrees of flexion, of shoulder flexion or lower, that you are getting the sternal fibers. This is also the reason why, like, if you ever see somebody trying to do like a max bench press and you ever see someone like lay down and then they arch their back doing that flat bench press, you know what I'm talking about? The whole reason they do that, and it's actually considered acceptable form, but you do that to essentially simulate a decline bench press. If I'm doing a decline bench press, you'll notice that you can do a lot more weight than even if you do a flat bench. And it's because you get more of the sternal fibers involved. So if you arch your back, even on the flat bench, you're going to recruit much more of your sternal fibers. Your clavicular fibers are your weakest ones of these. Now, this guy here has torn a pec muscle. You usually don't tear a pec in the muscle belly. You're tearing it really near the insertion point. So that's why typically you'd see like this armpit bruising, because you're getting a tear near that insertion point. Usually a pec is going to be torn when you go too far into horizontal abduction, similar to what you would do with, like, say, a chest fly. So if I'm laying down and I'm doing flies, that's getting into my horizontal abduction. Well, if I drop my arm below my shoulder level, that's going to put much more strain on my anterior shoulder. When I try to come back up, the strain I get is mostly on this near the insertion point, so near my armpit. And you'll feel it too. If you start out with your hand below 90 degrees of abduction, and you try to come up into abduction like you're doing a chest fly, you'll feel Yeah, there's gonna be some contraction along your sternal fibers, but your primary contraction you're gonna feel is right at your armpit. So you're putting too much strain on the insertion point when you go down like that. That's why, and this goes back into like say our stuff on torque, that you want to decrease the length of your moment arm. So you decrease the torque necessary to make that movement. You also never want to drop your hands below shoulder level if you're doing flies, because then that puts way too much stress on the anterior shoulder. Movements of the pec. This is going to assist in virtually everything, but its primary movement is going to be horizontal adduction. Now, the insertion point here is on the lateral humerus. Because it's on the lateral humerus and it comes over top anteriorly, it's going to help pull that shoulder internally. So just like I was saying before, with someone who walks and you see the back of their hand, that's because the pecs are going to pull you internally. So you have internal rotation there. Now, we talked before about, agonist, antagonist, synergist, stabilizers. And remember that agonist, antagonist tend to be geographically opposite of each other. This is also why, like, say, when you are like separating upper body exercises, you tend to group, like, say, back and biceps with chest and triceps, or pushing with pulling kind of thing. And whenever you are essentially doing one, so if you're doing anything that's chest and triceps, is going to be pretty much exclusively a pushing based motion. You're being opposed by the pulling based movements. The one big exception to this is the relationship between lats and pecs. So while lats are going to oppose pecs in some regards, they still will actually share a common movement. And that is internal rotation here. So your lats are the widest muscle you have in your body. Sartorius is the longest muscle you have. Glute max is the biggest muscle you have. The smallest muscle you have, I forget what the name of it is, but it's one of the muscles that's in your inner ear. But it's like all of a millimeter long kind of thing. Anyway, what is kind of weird special about your lats is their insertion point is on your anterior lateral-ish humerus, but they come inside your arm. So they're actually coming from behind your back and then through to the front of your arm. They don't come around the opposite side, which is why it still shares internal rotation with the pecs, among others. And if you were to hold your lats and go into internal rotation, you'll actually start feeling the lats moving. So even at, like, granted, I have terrible range of motion because I don't stretch and I'm out of shape, but if you feel your lats and you go into internal rotation, you should feel a contraction occurring. It's not like nearly as powerful as, say, feeling your sternal fibers of your chest when you do horizontal adduction, but you should still feel it. So pecs and lats share that same movement. I believe that was a question on your first lab exam. So If you would have had me from day one, you all would have gotten that right. Now, lats located in your back are going to move your shoulder in which direction?
Would it be down and back?
Yeah. So anything that's on your back is going to move you backward. The primary function of your lats is going to be shoulder or glenohumeral adduction. So in a lat pull down, it helps to adduct the humerus. And then it does shoulder extension. Teres major, don't worry about. Teres major is like the much less interesting older brother of Teres minor. It's like, I'm sure how Rob Gronkowski's brothers are in relation to him. Coracobrachialis, don't really worry about. Not really doing a whole heck of a lot for you there. Coracobrachialis is exclusively a synergist muscle. The only thing kind of noteworthy about it is how it interacts with your brachial plexus, because you actually get part of your part of the axillary nerve is going to go straight through it. But anyways, don't worry about coracobrachialis. All right, I don't want to get on rotator cuff because that's a whole thing. Where were the other two? Well, anyways, the last two I want to talk about here are really biceps and triceps. Well, I really don't have any good pictures, do I? Well, anyways, biceps and triceps, while these are usually associated with the elbow, do play a role with the shoulder. So biceps, along with brachialis, brachioradialis, are your primary elbow flexors. Triceps is your primary elbow extensor. However, they have an insertion point on or around the glenohumeral joint. Whenever you cross over a joint, you move that joint, which is why we'll see, like when we do like the foot and ankle, when we talk about gastrocs. So gastrocnemius originates on the distal femur. So because it originates there, it assists with knee flexion. Wherever you cross over a joint, you move that joint. Biceps, and most notably our long head of our biceps, inserts on the superior labrum. So it's going to assist with shoulder flexion. Triceps is going to also assist with shoulder extension. They're by no means the prime movers. They are the prime movers of the elbow, but they assist with your shoulder. All right, we are running close to time here. So instead of jumping into new stuff, I think we can call it a day here. When we come back on Friday, we are going to finish up with the rest of the shoulder. And then we are going to probably review for your final. And then I'll open that final up for your exam up for you. And then that'll be that. All right. So if you all don't have any other questions, you are all good to go. I will stick around to you all leave, but thank you so much for getting through all this with me. And then hopefully I see you all here on Friday.
I have a quick
Have a good day.
question for the exam.
Yeah.
Do we need to know the different types of sensory neurons like we do for the motor units?
You'll need to know, yeah, the three basic types of the motor neurons and what they do. So the alpha, beta, gamma ones. And just remember that alpha motor units are going to be the ones that do skeletal muscle, like voluntary skeletal muscle movement. Beta and gamma do sensory movement. So non-voluntary movement. That's about the extent of what you'll need to
Okay.
remember.
All right, got it. Thanks.